Hello. Hello. Hello.
Yeah.
Yeah.
Am I
Okay.
audible? Yeah.
Yeah.
Good evening, everyone. Thank you, Ritesh. It's my pleasure to introduce this evening to all of you to Dr. Amjad Maniar, who is a young and dynamic anesthesiologist. He's done most of his career as graduation, post-graduation at MS Ramaiah Medical College, Bangalore, and then a fellowship in regional anesthesia at Singapore. He has worked at many hospitals, and he's been a faculty in various academic activities related to regional anesthesia, more than 50. It will take very long if I enumerate all of them, but they have been at all levels, national and international. He's also organized many of them. I'm sure you can see me turning pages. This is all the CV of Dr. Amjad Maniar. He has publications to his credit, and he is a very active member of AORA. Besides these achievements, he has to his credit, he has, in this COVID era, devised or rather modified the aerosol box in such a way that it becomes more comfortable ergonomically for anesthesiologists to work, which many of us have used and found it very useful. It is so ergonomically useful that he even performed a USG guided supraclavicular block using the aerosol box and published a case report. Dr. Maniar will today speak on the quadratus lumborum block, and over to you, Amjad. Yes, over to you, Amjad.
Thank you, Dr. Vandana, for that wonderful introduction. Let me just get my... So a very good evening to everybody watching this webinar. I'm actually a little jealous of Dr. Sandip Diwan because he got the nice topic saying mysterious and curious and those sort of colorful words. But most of us who have been through the era of fascial plane blocks know that all the problems in regional anesthesia these days started with the quadratus lumborum block. Before these fascial plane blocks came in, everything was very rosy. We had upper limb blocks, we had lower limb blocks, we knew how it worked. And then came along these bunch of fascial plane blocks that changed the landscape completely. And I hope you can bear with me while I go through some concepts of this quadratus lumborum block today. I have nothing to disclose. I have saved this picture for many years now. This lady was an elderly woman who underwent a laparotomy for a sort of cancer surgery. She had multiple issues in her abdomen and multiple comorbids too. And for some spine issues, spine related issues that she was on anticoagulation, we couldn't put an epidural for her. And she was very demanding of high quality analgesia. So this was probably the first bilateral quadratus lumborum catheter that I had placed many years ago. And the results were quite dramatic. The patient this was the immediate picture in the recovery room. The patient was sitting up. She had very minimal opiates for a 7-hour surgery, and she was sitting up completely pain-free. And this was very characteristic over the years of what we saw when we did these sort of fancy plane blocks, the extremely dramatic level of analgesia that it produced. We were used to doing upper limb blocks and lower limb blocks, and it was a very predictable picture. The wear-off patterns would be similar. The patients would, when the block wears off, the patients would be in intense pain. But with these fascial plane blocks, especially the quadratus lumborum block, the quality of analgesia was phenomenal, and this was an absolute game changer for all of us. So what is it? It's an abdominal wall block, but we give it not in the anterior abdomen, not in the mid-axillary line, we give it in the posterior abdomen. And it's named after its relation with a quadrilateral shaped muscle called the quadratus lumborum. It is a fascial plane block, we all know that. It provides analgesia mostly for abdominal surgeries, though it has been noted to be used for hip surgeries also. Some reports suggest that it provides visceral analgesia. Mainly this was kind of an unproven concept, but when you have a patient who has undergone a major abdominal surgery and sitting with zero pain scores in the post-op, you can be pretty sure that your local anesthetic has taken care of everything. And this was the great drama that it provided. It could provide analgesia, allegedly, from as high as the level as T4 to as low as L2, though inconsistently, but this was the capability that we could expect from the block. When we look at abdomen analgesia, I like to divide the abdomen into an upper and a lower abdomen part. The dividing line would be somewhere below, just below the umbilicus. And you have a variety of blocks that are available these days, which you can perform for analgesia of these areas. The QLB was quite interesting because just like the erector spinae these days, the QLB could span across both areas, the upper abdomen and the lower abdomen, and provide surgeries where the incision spanned both these areas. So just looking at where we are in the body when we are trying to address the quadratus lumborum block, we are mostly towards the posterior lateral side. And if you look underneath, the superficial muscles of the anterior abdominal wall end somewhere around the mid-axillary line and just slightly posterior to that. And the only superficial muscles that you will see in the back are the latissimus dorsi and the serratus posterior. So when you look underneath these muscles, you see three large muscles, the erector spinae group, the quadratus lumborum, and the psoas major muscle. There's nothing really special about this muscle that has made it, such a popular aspect of regional anesthesia. It originates from the iliac crest, and it gets inserted into the inferior border of the 12th rib, as well as the transverse processes of the L1 to L4 vertebra. Its function, just like most of the muscles that control the spine, is stabilization and movement of the spine, as well as the pelvis. So when you look at these sort of blocks, whether it is peripheral nerve blocks in the upper limb or lower limb, it's always good to have a three-dimensional anatomy picture inside your head. So this is how the cross section of the abdomen would look somewhere in the lower abdomen area. On the superficial side, you can see the external oblique, the internal oblique, the transversus abdominis. This is where you would normally give a tap block. But as you move more and more lateral, you see the termination of the transversus abdominis muscle, and this is where the quadratus lumborum muscle is. And you can see that they are arranged pretty much in this pattern. And many of you have seen the shamrock leaf pattern. This is the arrangement of the muscles of the posterior abdomen. If you look at the sonoanatomy, and if you're trying to find where exactly you are in the scheme of things, right around in the center would be where the rectus would be, and these are where the abdominal wall muscles are. So as these muscles terminate, when we go somewhere near the posterior, this is where you see the quadratus lumborum muscle, and that is our site for activity. Getting closer into what the ultrasound picture is, if you can get an image like this when you're trying to do the block, you're pretty much set. You see that the external oblique terminates somewhere around here, the internal oblique terminates. By the time you reach the quadratus lumborum muscle, the transversus abdominis muscle has completely terminated. So what you see here is pretty much either the perinephric fat or the abdomen. The psoas major would come somewhere around here, and this is where the transversalis fascia along with the peritoneum would come in. It's very important to know where these structures are and how to identify them when you are trying to attempt this block. when you try to do a different approach to the quadratus lumborum block, the QL3 or the transmuscular, sometimes you require to use either a curvilinear probe or a much deeper approach. Some people like to get the shamrock sign view in the picture when they do this block. So this is where the transverse processes the psoas major, the quadratus lumborum muscle, and the erectus spinae. And this together appear like the leaf of the shamrock. And this is just a pattern for you to easily identify and attempt this block. Now, apart from the musculature and everything else that resides in this area, an important anatomical entity is the thoracolumbar fascia. Now, the thoracolumbar fascia has three layers: the anterior layer, the middle layer, and the posterior layer. The thoracolumbar fascia is the deep fascia of the muscles of the back. So it encloses all these three muscles. So the anterior layer is usually formed as, it's a very thin layer, and this is very different from the sheath that encloses the psoas muscle. So it's a completely different entity, and it's more or less a continuation of the transversalis fascia, and is seen mostly on the anterior surface of the quadratus lumborum muscle. The middle layer is usually seen on the posterior surface of the quadratus lumborum muscle, and the posterior layer is the thickest layer of the thoracolumbar fascia and is seen to enclose the erector spinae muscle. When we think of fascia, you immediately think of something, very dry, thin, fibrous, a very boring sort of structure when we talk about anatomy. But the thoracolumbar fascia is not that. So it is a very unique fascia which is covered with mechanoreceptors, and there is apparently a high amount of sympathetic fibers, neural lining on this fascia. So any blockade of the thoracolumbar fascia can lower sympathetic nervous system activity and may cause increases and decreases in arterial blood pressure. So the thoracolumbar fascia is interesting for this manner. It is also one of the fascias that we'll have to go through when we try to deposit the local anesthetic. So the quadratus lumborum block is almost entirely attributed to the work of Dr. Rafael Blanco, who described it at the ESRA Congress in 2007. And over the years, there has been a continuous evolution in the technique. There have been different approaches and methodologies proposed for this block. And for all of us, we know that this is purely an ultrasound guided technique. So when I said that there's been an evolution of these blocks, the initial description that came from Dr. Blanco was an entity known as the quadratus lumborum 1 block. And the area that you see here is the place where he proposed that we should put the local anesthetic. There is a name for this area. It's known as the lateral raphe. And your needle would probably come in this way, and you would try to deposit the anesthetic in this area. So this was the quadratus lumborum block, which was named QL1. Subsequently, he described the QL2 approach. So the QL2 moved further posterior and into this plane that you see here. Now this plane is interesting, and I'll tell you about this plane a little later. This plane contains an important entity, that is the abdominal branch of the lumbar artery. And many years ago, when I spoke to Dr. Blanco, he felt that there were two things that happened when you injected the local anesthetic into this plane. One is that it would travel between the different layers of the thoracolumbar fascia into the paravertebral spaces higher above. The next is he felt that this was the actual neurovascular plane which carried the local anesthetic into the lumbar sympathetic chain. So this was the mystery of the QL2, and a lot of us started doing this. Almost, probably a year later, the QL3, sorry about that description, this is the QL3, or the transmuscular block came out from an author named Jens Borglum from Denmark, where he proposed that the local anesthetic can be placed between the quadratus lumborum muscle and the psoas major muscle below. And he felt that this was a more appropriate area to place the local anesthetic. So he called this the transmuscular approach. Many of us call this the QL3 for various reasons. There's also different terminology that is commonly used with the block. The QL1 is sometimes called the lateral QLB because of its anatomical position. The QL2 is sometimes called the posterior QLB, and the transmuscular is often sometimes called the anterior QLB. There was a fourth variant called the intramuscular QLB, which involved deposition. This came from a Japanese author called Morochi, where he actually said that you could put the local anesthetic directly inside the quadratus lumborum muscle, and this would provide analgesia. I'm not sure how that happens, but probably as we progress in this talk, we'll get to the bottom of this. Can I request the person who put those inks to get rid of it, please? Yeah. So before the QLB got its due recognition, there was another block that came out. Many of you have heard about this, and I keep getting asked about this in relation to the quadratus lumborum block, the fascia transversalis plane block. Many of you might have heard about this. This came about in 2008 or 2009. And this was purely for analgesia of the iliac crest. So what they proposed was that the L1 nerve, the cutaneous branches that supply the iliac crest, often branch early, and giving a tap block for analgesia was not good enough. So they proposed putting the local anesthetic at the level of the fascia transversalis, and this would provide more wholesome analgesia of the iliac crest. So this is the area where they proposed that you would put the local anesthetic for a fascia transversalis block. And if you look very closely, it's not too far from where the QL1 would be. It's not very far from where QL2 would be. And really, when you're talking about volumes like 20 mils of local anesthetic, it's not very far from anything. And if you look at the image from the article, the dark area is where they propose it would be. So the fascia transversalis block is just another representation of the same concept of the quadratus lumborum block. But if we turn back the clock a lot more to 2001, and if you remember that a doctor from Ireland named Dr. Ruffy described the tap block, many people, when we think of the tap block, we think of those three muscles of the abdomen, and you go pop, pop, and deposit the local anesthetic. But the original tap block was actually a single pop technique done in the posterior abdomen in the Petit's triangle. And the Petit's triangle is an anatomical place where it is bordered by the latissimus dorsi, the external oblique, and the base of the triangle is the iliac crest. Now, if we interpret this Petit's triangle into an ultrasound image, this is how it's going to be. This is a familiar picture. I've been putting this all through the talk. The quadratus lumborum is right there on the left. And this is where the Petit's triangle would be. This is very interesting, isn't it? So what Dr. Rafi did was he would feel the posterior abdomen very carefully with his fingers and try to hook on to the latissimus dorsi. He would feel for the lateral border of the latissimus dorsi and put the needle in at the lateral border until he felt a single pop. And if we interpret that, look where the local anesthetic is going. So for all practical purposes, the landmark technique of tap block was actually the quadratus lumborum block as we know it today. And this was actually proved in this very interesting article that was available in 2011 on the spread of local anesthetic during tap blocks. And one of the groups underwent landmark blocks of the landmark tap blocks, and they evaluated them under MRI. And interestingly, they found that the local anesthetic was seen at the lateral border of the quadratus lumborum muscle in all the subjects that they tried this block on. And it behaved exactly like how we know the quadratus lumborum block to behave. So the quadratus lumborum block is actually an interpretation of Rafi's landmark technique. So this is how the blocks are. This is the QL1. This is where the quadratus lumborum muscle is, and you see the fill. Probably this fill is a little more medial than it should be that you see over here, but that's pretty much how a QL1 block would be. The QL2 block is very different. This is the quadratus lumborum muscle here. You can see the hyperechoic fascia and the needle depositing the local anesthetic very gently in this plane. That's the QL2. Ritesh was kind enough to lend me his transmuscular QL video for this talk. So this is with a low frequency probe. This is the rectus spinae muscle, and this is the psoas muscle that you see here. This little structure, because it's a high frequency probe, is the quadratus lumborum muscle. So the transmuscular QL is an injection between the QL muscle as well as the psoas muscle. So this is the general area where you would expect the local anesthetic to be. If you look at intramuscular QLs, again, every now and then you might find when you're trying to do either a transmuscular or a QL2 block, you might find the local anesthetic sitting inside the muscle. So this may be an intramuscular QL because of the clear definition of the thoracolumbar fascia all along. So the psoas muscle is somewhere down there, and you can see very clearly that the local is filling up in here. This is actually a catheter that has been placed inadvertently inside the muscle. So when we're looking for the fill, that's the kind of fill we got. So this is very typical of an intramuscular QL. So the question is, and this is not just for the QL block, it's in general, how do fascial plane blocks work? One is we know all blocks provide some sort of phenomenon when the local anesthetic comes in direct contact on the nerves. If there's a nerve in the area, you get a block. So that's one way if it works. When you look at the intercostal nerve blocks, because that area is a richly vascular area, as well as the muscle structures are extremely thin, there is diffusion of local anesthetic through thin planes, which can come in contact with the nerves, which is why that many of you who do tap blocks will see that many of the times, in fact, most of the time, you are probably not between the ideal facial layers, and a bit of your local anesthetic has gone intramuscular, but your block does work. Sometimes it takes a while to kick in, but it does work. So the diffusion of the local anesthetic may be another phenomenon that makes fascial plane blocks work. Of course, this is the most mysterious part of fascial plane blocks, the travel of the local anesthetic towards some significant neural structures. Most of the time when you want that really good high quality anesthetic or analgesic effect, it is spread towards the neuraxis. And there is a fourth phenomenon that we'll touch upon today, the intravascular action that may be happening. So if we talk about the QLB and we are looking at neural structures in the vicinity that may be directly affected, it is the L1 nerve as well as the T12 or the subcostal nerve. Both these entities lie in the area between the psoas muscle and the quadratus lumborum muscle. And this is how an image of it would look. This is actually a nephrectomy. This is the psoas muscle that you see there. This is the QL muscle. And if you look very closely, you can see a nerve. Probably this is the T12 nerve running across the quadratus lumborum muscle. And this is where it actually lies when you look at the quadratus lumborum muscle. This is the area where these two nerves actually come out, and they head towards this plane, which is the transversus abdominis plane. So any local anesthetic in this area, this is the site of the QL1, this is the site of the QL2, this is the site of the QL3. So any local anesthetic deposition in this area will directly affect the L1 and the T12 nerve. So this is great for surgeries such as the cesarean sections, inguinal hernias, fan and steel incisions. It's an absolutely great area to block, which is why many of the articles, especially this first one that came out from Dr. Blanco, talk about providing great analgesia below the umbilicus, that is the lower abdomen. So this was the initial trial that he had done for analgesia after cesarean sections. And basically he found that the tap blocks tends to act faster, but the blocks like the QL block tends to have a much longer effect. Oops, just one moment. Yeah, so this is another block, another QL block done for lower abdominal surgery. Again, very good quality of analgesia provided, much better than the TAP. So you can, if you actually look through PubMed, you'll find that most of the articles, most of the studies that happen actually look at providing analgesia below the umbilicus. So that is one way you can provide very reliable analgesia using the QL block. So the other concept that we are fascinated about is the cranial spread. That is, the local anesthetic delivered somewhere around the flank tends to travel upwards towards the paravertebral space. Just give me a moment. I will just try to clear my slide up. So these were initial images again from Dr. Blanco and showing the spread after QL2 block. And you can see the dye spread towards the the 12th and the 11th rib, as well as medial towards the neuraxis. Yeah. So the other entity that, just one moment, please. I'm just having a little bit of trouble with my slide here. Yeah. The other entity that we encounter when we approach the QL2 is the lumbar interfacial triangle. So this area is somewhere between the erector spinae muscle and the quadratus lumborum muscle. It's also known as the lift. So it is just a formation, a kind of triangle formed by the thoracolumbar fascia. And because this is a known entity, we can easily target this and access the plane required to enter the QL2 block. The lift is formed by the posterior and the middle thoracolumbar fascia, as well as the posterior aponeurosis of the transversus abdominis muscle. And theoretically, it's divided into two compartments, and the outer compartment is the site where we are supposed to be injecting. But this is again something very theoretical. We don't really see these sort of layers when we do the ultrasound guided block. But a rough area, you will find the zone to inject somewhere. You can see the needle over here and the injection happening. Let me just get my pointer back on. Yeah. So somewhere in this area is where you would find the lumbar interfacial triangle. So this is a cross section of where the lift would be. This is the lift. This is the QL muscle over here. This is the erector spinae. And this is where you would want to inject. So in terms of the ultrasonic image that you would want to approach, this is where the transversus abdominis ends. And this is the kind of zone where you would look for the lift. The lift also contains the abdominal branch of the lumbar artery. And that is one identifying factor that you must keep in mind, because any trauma to this artery could lead to massive hematomas. You must also look at the lift as a three-dimensional structure. So the thoracolumbar fascia and the lift ascends upwards and is part of the insertion of the muscles into the transverse processes of the upper lumbar vertebrae. So if you look at this image that was taken from Dr. Blanco's post, you can see that there is a trickle of dye probably where the lumbar sympathetic chain would be. So we had this discussion and he was very sure that nerves, as you know, the neurovascular plane, nerves as well as vessels travel together. So entering the plane of that abdominal branch would perhaps take the local anesthetic deeper inside into the sympathetic chain. So these are all concepts that were thought about. Again, there is no solid proof for a lot of what I'm saying today, but it's just something to keep in mind. When the transmuscular approach came along, uh, again, the interest was to see whether this once again spreads towards the thoracic paravertebral space. And the same authors conducted a dye study on cadavers, and they found that 100% of the time there was spread from the transmuscular area via the medial and lateral arcuate ligaments into the thoracic paravertebral area. Now the QL2 would create a spread via the thoracolumbar fascia, which is connected to the endothoracic fascia when you go cephalad. So in the case of the transmuscular block, the spread was likely to happen through uh, the medial and lateral arcuate ligaments. This was a study looking into the different cadaver studies on the spread of local anesthetic after quadratus lumborum blocks. This was by El Sharkawi. It was, I think, last year. So they looked at a few studies, and only two studies, one done by Dam and the other done by the author himself, showed that the local anesthetic in cadavers can travel up to the paravertebral space. In different other studies, the kind of spread achieved was very different. There would be lateral spread. One of the studies by Carlin, which I'll talk about, actually showed that the transmuscular quadratus lumborum block can create spread to the L1 and L3 nerve root, which is rather unique, and their reasoning why it may be useful for hip surgeries. This was that study I was talking about by Carlin. And the QL1 and QL2 blocks did not have a very fascinating spread. They actually spread into the tap plane. But it was the transmuscular block that was very interesting. It went on to stain the L1 and L3 nerve roots along with the genitofemoral nerve, the femoral nerve, the obturator nerve. All these entities got stained. But if you look at the area of injection, the point of injection that they illustrated uh, in this paper, it looked like their injection was very, very close to the transverse process, very close to the neuraxis, which could be the reasoning. Technique plays a huge role in the effect of the quadratus lumborum block, which is probably the reason why many people tend to have different results in terms of spread when they do this block. I was talking about intravascular absorption. This is something that people don't talk much about, but we have to look into this when we talk about fascial plane blocks. Now, there are two concepts to what we do, anesthesia and analgesia. And you ask yourself the question, what do fascial plane blocks provide? Do they give you anesthesia or do they give you analgesia? Most of the time, and you look back at your own practice, and you're going to find that when you do these blocks, you're doing it for analgesia. Anesthesia is very specific. It's a very pure topic. The if you are trying to provide good anesthesia, you should be able to create conditions that allow the patient to tolerate a surgical incision. So you either do a GA or you've seen complete blockade of the nerve when you do, say, a beautiful brachial plexus block. But analgesia is a very, very hazy term, and it's time we actually look for, clear definitions of it. Analgesia is pretty much pain relief in our case after surgery. Anybody can do it. You don't need to be an anesthesiologist to give analgesia. You can give IV oral medications. People say you can do acupressure, acupuncture, hypnosis, funny things like that, which provide analgesia. And in the end, you might just have a patient who is really tough after surgery. He doesn't need much analgesia. So analgesia is a very vague term. We don't have clear definitions of it. And here we are with facial plane blocks providing analgesia. And this is why I'm harping on this topic a lot, because I looked up PubMed today. I saw 233 articles on the quadratus lumborum block, but only one case report where they used the quadratus lumborum block to provide anesthesia for a surgery. And they used it for a very predictable open inguinal hernia repair. I said earlier, L1 and T12 are right in that spot. So inguinal hernia is a great place to provide surgical anesthesia with the quadratus lumborum block. But there was just one article on it. There's the other concept of what happens when you give a local anesthetic, a nice strong dose of local anesthetic into a facial plane. So there's a review article that looked at 15 studies that measured the plasma concentration of local anesthetics after TAP and rectus sheath blocks. There's only about 1 or 2 papers on the effects with quadratus lumborum block, but for all practical purposes, we look at ropivacaine in a facial plane block and see what actually happens to absorption. Now they took 2.3 micrograms per ml as the toxic threshold for CNS symptoms. And these were the various doses that they used, 200 milligrams, 50 milligrams. There were 2 studies which used levobupivacaine and lignocaine. So we'll just ignore that. That's the one lignocaine one that you see up there. But if you keep 2.3 as the cutoff, you'll find that in some cases, the intravascular absorption of local anesthetic after a TAP block comes very close to systemic toxic levels. Though none of these manifested as LA toxicity, the plasma levels seem to reach that high a level. And this levels of local anesthetic absorption is dependent on many things, mostly the patient condition. Lower systemic levels of protein actually lead to higher plasma levels, as well as states like trauma where there's been a lot of blood loss, pregnancy who are pregnant. LSAS patients are our prime customers for TAP blocks. Cardiac conditions, renal failure, hepatic, um, they're all factors that influence the LA absorption. Also, very interestingly, is that if you get your local anesthetic to spread over a large area, like in a facial plane block, the greater systemic absorption occurs. So this is the reason why when we do facial blocks, that is whether it is a PEX block, it's a serratus block, TAP blocks, QL or erector spinae blocks, there is a fairly large amount of local anesthetic systemic absorption. And what happens when this goes intravascular? It's very interesting. Murli is here today. He's a chronic pain guy. So he knows the chronic pain guys have been using lignocaine intravascularly for years. And it's only recently come into acute pain. And in acute pain, when you use lignocaine, which is the only drug we have that we can give intravascularly, there is significant anti-hyperalgesic and anti-inflammatory properties. And mainly, it reduces sensitivity and activity of the spinal cord neurons and a concept known as central sensitization. And it decreases NMDA receptor depolarization. There's a decrease in systemic inflammatory markers in patients who receive intravenous lignocaine perioperatively. And this is, again, something very interesting. The clinical benefits usually exceed the half-life by about 5.5 times. So if you stop a local anesthetic, like lignocaine going intravenously, you might see the clinical benefits in some studies up to 24 hours. In some of the studies, it can go up to 72 hours. In fact, one of the studies that said that the peak effects of analgesia caused by IV lignocaine may be seen as late as 36 hours post-surgery. Last month in Daring Discourse of RAPM, there was a bit of a riffraff happening, and this was a letter written by Dr. Longquist and Professor Karmakar regarding the erector spinae plane block and other fascial blocks in general. And they shared the same thinking that there is systemic plasma levels of local anesthetic when you use it in a fascial plane block. And they proposed that future studies looking at analgesia from fascial plane blocks must take into consideration and measure the systemic local anesthetic levels, because they also felt that this creates some amount of analgesia. Moving on to some frequently asked questions. This is not going to be much of a technical talk, it's more of a concept talk of the QL block, but many people like to know how much do you inject for a QL. Pretty much, I would say every block these days we give 20 ml syringes. And the reason why we give 20 ml, where few studies say 20 ml is good, plus after 20 ml, they only make 50 ml syringes. So that's probably the reason I use 20 ml for all my blocks. But on average, pretty much you can give 15 to 20 ml in the QL area. But of course, you need to measure body weight and see that you don't exceed toxic doses. What position can you do the block in? Well, it depends how comfortable you are with the needle and syringe in your hand. Most people like to do it in the lateral position. You can do it in the supine position, as you can see over here. You just need to ensure that you get enough space in the posterior flank so that you can wedge your probe in there and image the muscle clearly. Apart from the usual bouquet of complications with regional anesthesia, the usual complication that we can expect are injury to the abdominal viscera, because the kidney and the bowels are very close. If you don't look out for that abdominal branch of the lumbar artery, you can hit it and create a lot of bleeding. And though theoretically they say that you can block the roots if you go too much towards the neuraxis, I haven't seen it happen in my years of using this blockade. Can you use it elsewhere, just like they use the quadratus lumborum block pretty much everywhere in the body? Yes, it has been used for hip analgesia, but again, this is subjective to your usage and whether you want to really put this for a hip surgery. Of all the approaches we have, which is the best approach? Well, I'll leave it up to you to decide, because pretty much when you put 20 mils of local anesthetic around a small area like that, you're going to pretty much get spread all around the quadratus lumborum muscle, and it probably doesn't matter. I don't think there are too many studies that have compared each of these approaches and found that one is superior to the other. The outcome of studies have been vastly variable, which means that there's still a lot of scientific investigation that needs to happen before we can find the actual reason why this block works. So what would you select if you're doing a lower abdominal surgery? Pretty much anything would go. You know that L1 and T12 are very consistently blocked with this block, so you can pretty much give anything. I would probably avoid the intramuscular block, but pretty much any of the three techniques would work. Again, you need to be a bit clever when you're doing the QL for upper abdominal surgeries. The gold standards would probably still be the epidural and paravertebral if you can cite them. But if you had to make a choice, it would be either the transmuscular or the QL2. You need to look for a technique that can reliably take the local anesthetic into the paravertebral spaces above. In conclusion, probably I'm just sticking my neck out here and making the statement. There are multiple modes of action for the quadratus lumborum block. It may work locally on the nerves. It may have a distal spread. or you might have systemic action. And who better than Dr. Sandip Diwan to talk about the ESB, which has largely replaced the quadratus lumborum block in today's practice. Thank you.
Thank you, Amjad. Over to you, Vanna ma'am. I'm unmuting you, just a minute.
Am I audible?
Yeah, ma'am, you're audible.
Yeah. Thank you, Amjad. Thank you so much for that lucid talk on such an elusive block. Thank you so much. And I hand over the proceedings to Dr. Murli Thondabavi to take their evening forward.
Good morning, good afternoon, good evening to all the viewers. We are going live on Facebook and also on Anesthesia TV. So we have a lot of participants from across the world. Now, taking this evening forward, we have
Only,
yes.
can I interrupt? Can you take the questions, because there are a lot of questions in the chat box considering the QL block.
Should we take the questions now or at the end?
No, we can take it now so that it will be relevant to the topic, isn't it?
Yeah. Okay. Fine. So we have a lot of questions which have come up for Amjad's lecture, and I'm sure he did answer a few FAQs at the end. Now, to start with, we have Abhijit Nair, who is asking a question. He says he's heard Dr. Boglam's lecture, and he says he performs the QLB with the sitting position prior to induction in block room. So he wants to know from Dr. Amjad, do you do QLB in sitting position, or have you done QLB in sitting position?
I have never done it in sitting position. It's quite interesting that he does it in sitting position. I haven't, but then position, again, it's something of your ergonomic preference. I'm not sure whether gravity would actually influence the flow of the local anesthetic in the sitting position. But again, if Dr. Borglum's doing it and he's getting his local into the paravertebral space, I suppose it doesn't. So there's a lot of fluid dynamics that we need to keep into consideration when we're expecting this sort of flow towards against gravity. So I haven't done it. To answer the question, I haven't done it in my practice. It's always been lateral or supine. I'm very lazy in positioning patients. So I just like to do the block the way they are. So if they're lying down flat on the bed, I just do it in supine.
Okay. The other question which has come up here is regarding robotic surgeries, laparoscopic robotic surgeries. So can QL blocks be used instead of a 4-quadrant tap block?
Well, yeah, it depends. See, it's not about the block. It's about where you're trying to provide analgesia. So you're going to be looking at the incision. You're going to be looking at the amount of surgical dissection for that particular surgery, whether it's a bowel surgery, it's a nephrectomy, or it's a prostatectomy. It really depends on what you're trying to block. Now, if you're looking predominantly at the incision, you're looking at something like an umbilical level incision, yes, the quadratus lumborum block can provide analgesia there. If it's something like a lower abdominal incision, yes, a big yes for that. The local anesthetic goes on the nerves right there. It's going to provide analgesia. Are you able to technically and reliably push the local anesthetic into the paravertebral space to raise the level? Yep, if you can do that most of the time, why not? Does the local anesthetic go intravascular and cause some sort of a magical systemic analgesia? Yep, it does. So the answer is yes. You can use it for any of the abdominal surgeries. And of course, if it's a robotic and it's laparoscopic, you'd probably want to do it bilaterally.
Okay, I'm going to combine a few questions here, just going through the questions. One is something which is common. It says, what exactly is the clinical use of knowing so many varieties of QL blocks? Is the part A of the question. The part B is, what is your choice? I'm sure you clarified it during the talk, but just as a take-home point, can you just elaborate on that? And third thing, as you mentioned, one regarding the systemic absorption. Second, there's a question about myotoxicity as to which of the QL blocks would lead to less myotoxicity. So there are like three questions in one.
Okay. Why do we have so many approaches? You can ask that question for, pretty much every block that we have in regional anesthesia these days. Small variations of the needle end position are given block a new name for the block, and it leads to confusions. Uh, is it relevant that we place the needle 1 inch away from another position and expect it to do something very different? Common sense will tell you probably not, especially when you're using such large volumes of local anesthetic. Do we need so many approaches? I know that there are a variety of approaches for the quadratus lumborum block with different names, many of which I have not gone through in this particular talk. I have not used any of those apart from QL1, 2, and 3 in my practice. And based on your technique, you should be able to create all the phenomenal effects of the QL with just these three simple techniques. Do we need all of them? No, we certainly don't. We want to keep our regional anesthesia very simple, very attractive. The moment you start complicating it with different names, different techniques, you pretty much lose half the audience. So let's keep it simple. I think QL 1, 2, 3 is pretty much what we should be looking at. The concepts are very strong on these three approaches. What was the second part, Murli?
Myotoxicity.
Yeah, so there was a rebuttal to one of the papers by Morochi, who was depositing his local anesthetic bang in the middle of the quadratus lumborum muscle, saying that we don't know so much, we don't encounter myotoxicity, but we know that local anesthetics, especially ropivacaine, can create that sort of problem. Pretty much every fascial plane block that we do, there are small amounts of local anesthetic that seep into the muscle. But we shouldn't be aiming to blatantly put it mid-muscle. We should aim to hit the facial planes or at least the border of it. And pretty much, which is why I didn't give too much importance to the intramuscular sort of injection approach, because I don't think it's a great idea, even if you're using dilute local anesthetics, to deposit bang in the middle of the muscle. The third one, Murli?
The same thing. I think you covered it with systemic toxicity.
Okay.
But many comments on the chat box, praising the talk, and everybody is liked it.
Amjad, can I intervene?
Yes,
Amjad,
Ritesh.
there were 2-3 good questions. There was a question from Dr. Jasbir Chabra from UK. Do you regularly look for the lumbar artery when you are performing a QL block? And if you have got any video so that it clears the concept, because that is a artery, that is a complication we don't want to encounter.
I would be very disappointed and very worried if I did not see that artery. That is the kind of importance that I place on it in my practice. In fact, I don't go looking for the QL muscle. I go looking for the artery. And when I find that artery, then I look around and say, hey, okay, hey, here's the muscle. Let me do the block, but let me just stay away from this artery. I personally know of 2 traumatic experiences that happened where the artery was injured during the block, leading to a laparotomy in the post-op period. So you have to look for that artery. I'm sorry I didn't get the image. I will try to look for an image in my other computer showing the artery. It is easily seen, and if you look at the quadratus lumborum muscle, it's usually seen around the 11 o'clock position, and if you scan up and down, you'll see it running more and more towards the neuraxis. So it is imperative that you look for this artery and avoid it. Go close to it. By all means, enter that facial plane. It's a nice place to be, but keep your needle away from that artery. It is downright dangerous. And because it's fairly deep, it's a difficult vessel to control the bleeding with. You're going to struggle to put pressure and stop the bleeding, and it makes a big mess.
And there was a question. It's a very good question. Where to deposit the drug? Outside the fascia or inside the fascia? And where do you, in which approach you will prefer putting your catheter if you are using it?
Okay. Okay. So in theory, in theory, you need to deposit between the layers of the thoracolumbar fascia. Okay. In practice, you can't see those layers unless you have Shiva's machine and you have a pristine patient, which in practice you don't see these multiple layers. But when you do, if you talk about dual guidance, so another form of dual guidance is to actually feel what the needle is telling you when you're doing ultrasound guided regional anesthesia, pops and little different things. You should be able to discern between fat, muscle, fascia. So that is one way of approaching it. You know that if you're heading towards something and you feel a pop, you're probably crossed one layer of the fascia. You inject a little bit, see the spread. Okay. Again, I can say this is the way to be, but in real life, when you have a large obese patient, you're probably thankful you reach a point where you can inject. Uh, that, that's where these kind of blocks seem to be a little bit forgiving. If you make these sort of technical errors in a brachial plexus block, you will find that there'll be some sort of sparing. But with facial plane blocks, there seems to be some sort of an error margin. So if you're pretty much close to the facial level, you should be able to get some sort of a block going, at least blockade of L1 and T12. But if you want your local anesthetic to start traveling above, so you look for certain signs, you try to make use of the plane where the artery is. You look for that phenomenon where you inject a little bit of local anesthetic, the area expands and then it collapses. It expands and it collapses. So you know you're in some sort of a plane. If you're inside a muscle, it goes boom and it stays boom, open like that. But when you see that expansion, collapse, you know you're inside some sort of a facial plane. So you use these sort of markers to work your way around and get your block going. As for the catheters, when I started, I think we used to put it more or less between the quadratus and the psoas, the transmuscular area. You could approach it from the abdomen, or you can even sneak it into where the QL2 area is very carefully, of course, because that's a big 2E needle that you usually take in very close to that artery. And really knocking an artery with the 2E needle is never a good thing. So either place QL2 or the transmuscular areas between would be ideal.
Okay, I think we have covered all questions. Murli sir,
Ritesh,
over.
Ritesh, one question was that can the QL block can the QL block be used for iliac crest bone harvesting? We are faced at times with a situation when there's a malunion of the ulna or radius. You can do it comfortably under the one of the upper limb blocks, but the challenge is to take the graft. So can we do it under this?
Yeah, so you'll have to be a little smart about it. The iliac crest is actually really painful, isn't it? Most of the time, patients will complain of pain at the bone harvest site rather than the actual surgical site. The fascia transversalis block addressed this problem, which is pretty much an interpretation of the QL1. They're pretty much the same, mainly because L1 seems to branch earlier when it is supplying the iliac crest. So you want to get these early branches blocked much further posterior. Uh, Whether you're able to cover the skin on that exact spot, whether you got everything, again, really it's difficult to blanket it, because again it's a bone, it's osteotome, they're very painful. Unlike soft tissue surgeries like the inguinal hernia. So again, whether you can do it purely under a quadratus lumborum block, I don't think I have. I've done several surgeries of the inguinal hernia purely under the block, but not a high risk. But I have used this block regularly to provide analgesia in the iliac crest area. So again, it's anesthesia versus analgesia. Up to you in your practice.
Thank you. Over to you, Murli.
Yeah, so going ahead, we have the curious and mysterious erector spinae block. This is a block that has come into practice from 2016 onwards in both acute and chronic pain. And we have none other than Dr. Sandip Diwan. We can call him now the Sherlock Holmes of regional anesthesia because he's going to be talking about the mysterious pain block. Now, it doesn't require much of introduction, but I'll say a few lines. He is a senior consultant at the Amjad Hospital in Pune, a pioneer in ultrasound regional anesthesia in India for the past couple of decades. One of the founder members and the pillar of Academy of Regional Anesthesia, and presently work as the academic director and the editor-in-chief of the International Journal of Regional Anesthesia. As you all know, he is a faculty at the national meetings and a lot of international meetings as well. A passionate mentor and teacher on workshops, especially the ones where it involves anatomy and cadaveric workshops. He is the author and editor-in-chief of a textbook on regional anesthesia and has contributed many chapters to other anesthesia textbooks. He is also a chronic pain physician, and my association with him is hand in that front as well. Not only is a brilliant anesthetist and regional anesthesia enthusiast, but also a fitness enthusiast, and I've learned a lot from him in the last 20 years of an association. So I'll hand over the forum to Dr. Sandip Diwan to take us through the erector spinal block, and I'm sure he's got a lot of his work with regards to the patient pains and cadaveric strains. Over to you, Dr. Diwan.
Murli, can you hear me now?
Yes, sir.
Yes,
We can hear you.
yes, we can hear you. We can see your screen. Please carry on.
Okay, thank you so much. Thank you, Dr. Murli, for that introduction. And I really love hearing your lectures whenever you do that. I thank Dr. Amjad for that comprehensive lecture on the quadratus lumborum block. And we welcome to this AORA webinar through Sancheti Hospital, where I've been working for last 5 years, and they have given me a real good academic platform as well. So we move on to the talk, which is the curious and the mysterious plane, which I've been doing a lot of work on this. Now, this was an attempted thoracic paravertebral block in an obese patient, and the catheter was placed with an infusion of 0.2% at 8 ml per hour with a 40% pain relief. Now, once I did that, I was quite surprised that I got the thoracic paravertebral so easily because she was quite obese. As you can see, the distance from the skin through the fat and the muscle plane and then to the costotransverse junction. So I did a contrast study, and to my surprise, I found that the contrast was lying just above the erector spinae muscle. In the axial view, you can see the contrast lying as well. So I thought this might be a new block, but then I easily forgot that incidence. And then to my surprise, I found the article which was by Ferrero, and he mentioned about 5 cases, two patients with metastasis to the rib, where he exactly deposited the local anesthetic just below the trapezius and between the rhomboid and the erector spinae, where I had deposited that local anesthetic, and 3 patients with VATS. So these patients, the local anesthetic was deposited just above the transverse process and below the erector spinae muscle. So I really missed that bus because I would have been the first to notify this particular block. But nevertheless, this is the paravertebral space, which is bounded anterolateral by the pleura, medially by the intervertebral foramen, and posteriorly by the costotransverse ligament. So you have to place the local anesthetic for erector spinae block deep to the erector spinae muscle. Now, the cadaveric study by Fodoro and group, they mentioned that the contrast, it lies over the erectospinal muscle. Deep to that, you have the costotransverse foramen, which really do not have any local anesthetic going into it, but they mentioned the dye going into that particular area as well. The contrast studies mention the dye which occupies the costotransverse foramen, but this is a volume rendering technique, and it really doesn't have the axial, the sagittal, as well as the coronal images, which will help to identify the exact placement of the contrast in those particular areas. So what is ESP? You need to explore the anatomy. So in Barcelona, where I collaborated with Xavier Sala Blanche, we dissected in 2 cadavers the erectospinal plane, and we did injections, but these were in the cervical and the lumbar area because thoracic area was explored a lot by then. Now this is the dorsum of the fresh frozen cadaver. This is the spinous process, and this is the transverse process. The protuberance, what you see, is the transverse process. Now, in between the transverse process connected to each other is the intertransverse ligament, and that's a very important barrier because that's a thick barrier which goes to a certain depth here. And if you see the transverse process, medial will lie the medial erectospinal plane. We have removed the spinalis, the thoracic muscle from the medial aspect, and you will see the bare area which lies here. And we also have reflected laterally the longissimus coli. The iliacostalis will lie more laterally. So you have got 3 erectospinal muscles over here. So the thing is that you have a deep erectospinal plane which is lateral to the transverse process, and you have a medial erectospinal plane which is called also the retrolaminar plane. Now, if you see the floor of this particular plane, you will see that it's all knitted, it's all interwoven, and you would really find any gap which will allow the local anesthetic to pass from this plane ventrally or anteriorly. So that's the problem here. And several cadaveric studies will give you some very confusing and very questionable solutions to that. So now in the literature, if you dissect the pooled study which was done by Banch, he mentions that Fodoro, when he first described this in 2016, there was a surge in the publications, and most of them were a single shot and at the level of thoracic, and there were rarely a cervical or a lumbar and continuous techniques. And 90.5% of the time, there were case reports and series. 5.5% were cadaver studies, 2.4 were randomized controlled trials, and most of the publications, they came from Turkey. And they mentioned that it's a successful paravertebral surrogate with simple, superficial, safe, and is devoid of any complications. Now, if you consider a pooled review of 242 patients, the limitations of these are the reporting bias, low-grade evidence, lack of clinical trials, and there is no quantitative evidence of the ESP efficacy. And so we are back to square one. Now we need to analyze, considering the cadaveric, the clinical, as well as the contrast studies, and then come to some conclusion. So do we have the answers in the thoracic area? Is the ESP a paravertebral surrogate? That is what we need to find out. And we do this by dissecting through the cadavers, clinical, and contrast studies. So analyzing the cadaveric studies, I take a few of these studies where this group, they mentioned that if you inject 20 ml at the level of T5, there is a cephalocaudid and a lateral spread. Dorsal rami is stained. This is the dorsal rami which gets stained, and the drug runs from cephalad to caudid along the erectospinae, but the ventral ramus is not stained at all. So this is what the group mentions. In another 20 cadavers, comparing the retrolaminar with ESP with 20 ml, you could see the dye spread on the back of the muscles. But at this point, you could see the spread which was on the ventral aspect and stains the intercostal nerve as well. But this is just one single intercostal nerve. And this we find it quite usual because we have done a few cadaveric studies which are unreported. And we saw that there is a single or maybe 2 levels where the intercostal nerves are stained. So is it important? That's the question. My friends Luke and Xavier Sala, they conducted a study again And they found that there is no contrast which spreads beyond the transverse process or beyond the costotransverse junction, and everything is behind the costotransverse junction. There is no ventral spread, there is no paravertebral spread, and the ventral rami here, you will see that they are not stained at all in any of these cadavers. So we have something from the cadaveric studies with opposing mechanisms. Again, there was an unpredictable injected spread of erythrospinal plain block in human cadavers. They don't have any, they did study 11 fresh frozen cadavers, but they don't have any figures. What they have is this graph particular where they have these cadavers and they show that there is an unpredictable spread, erratic spread in among all these fresh frozen cadavers. But one thing they acknowledge, the changes in the intrathoracic pressures, it might lead to anterior spread of the solution. And this might be true because with the phases of respiration, we see the spread and we see the delineation. When you mark at 0 hours and you mark at maybe 8 hours and then at 24 hours, with a continuous infusion, the spread, it keeps on increasing, and the sensory delineation, it keeps on increasing. So that is one mechanism of spread, and the other would be the tensile strength of the tissues in the cadavers will be different from the live humans. Coming to analysis of clinical studies in the thoracic era, in the rib fractures, some of these groups through case studies and case studies have mentioned its use, and it is being now routinely used for the multiple rib fractures. And this retrospective cohort by this group, they mentioned that the pulmonary function increases in 24 hours and the NRS is decreased by 39% for the first 3 hours. So if you take just 40% decrease and just for first 3 hours as a successful block, I'm not sure whether you can mention it as an established block for multiple rib fractures. But they acknowledge that there is a possible benefit in anticoagulated patients. Now, my colleague Abhijit Nair has cautioned the use of erythrospinal plain block in patients with abnormal coagulation or coagulopathy. But at the same time, there is a rebuttal from another author who mentions that it can be really used because the erythrospinal plain block, the muscles can be compressed in an unlikely event of hematoma formation. So Abhijit is there on the forum, so we can have some answers from him. Coming to thoracotomy, there's a weak evidence regarding the use in thoracotomy. They have used in lung transplant and in thoracotomy patients. The problem with this was found by this author who mentions that there is no sensory delineation in the anterior part of the thorax in the parasternal area with erythrospinal plain block. And this might be true because we did find the problems of using erythrospinal plain block in sternal fractures. Nevertheless, there are incidences or there are reports of ESB being used in cardiac surgeries. This randomized controlled trial, a prospective study in 60 patients compared with fentanyl infusions, and they found that the opioid VAS and adverse effects were less. And definitely in ESB group, you will find the VAS scores were less with the low requirements of fentanyl, as well as the adverse effects were less in this particular group of patients. So ESP definitely help in comparison with intravenous fentanyl, but they all acknowledge that there is no comparison with the gold standard thoracic epidural or a paravertebral block. Coming to breast surgery, which has a lot of articles which have been mentioned where ESP can be used. They had a single case report in a high-risk case when this was given at the level of T5, 20 ml, and they mentioned its use as an opioid sparing and immunomodulator. At the level of T4 with 20 ml, they found that the 65% morphine sparing in a randomized controlled trial. But again, they have a problem that it does not block the anterior cutaneous nerve, which supplies in the parasternal area and the supraclavicular nerves. And definitely in this article, they mentioned the limitations where they have two failures of ESP and they use transverse thoracic plain block as a rescue. And remember, they use the thoracic paravertebral block as a rescue analgesic for the ESP block. So the breast is supplied by a lot of these nerves, which you can see from the lateral aspect. All these nerves will supply the breast, and the medial aspect, which is again supplied by the lateral divisions of the anterior cutaneous nerves. A lot of blocks have been mentioned: the PEG SAP and the pectointerfacial plane block, the anterocutaneous nerve block, as well as the ESP. But ESP, whatever they have been mentioned, they are all not randomized trials, and there is a controversial spread, as we have seen earlier. So the question that haunts me is whether the ESP blocks the pectoral nerves, whether it blocks the anterocutaneous nerves. It can be used in which breast surgeries, and at what levels it would be useful, at the T2, T3, or T4. That's the problem. So they acknowledge that the SAP and the PEX is better than ESP for the breast surgeries. Coming to abdominal surgeries, I'm concerned about the visceral pain relief, though case series have been reported in all these cases at all these levels from T6 to T12. And there are randomized controlled trials where they mention again low VAS scores for the first 3 hours with low opioid consumption. I'm not sure whether you can take just the first 3 years as a successful block. And again, in another randomized controlled trial for abdominal hysterectomy, they mentioned the total fentanyl consumption has gone down with 14% in the perioperative period and 37% in the postoperative period, with VAS of decrease in the first 12 hours. So this is a good study that we can really look into. So this they gave at the level of T7, and this was done at the level of T5 and T6. Now, does it produce visceral anesthesia? Now, this was a study which mentioned about what I was mentioning was about this study: 14% decrease in the intraoperative and 37% decrease in the postoperative for the first 6 hours. And this is supported by 2 cadaver studies by Ferrero and Young, and 2 clinical studies by Kijin, who used it in bariatric surgery, and this person who used it in another patient for laparoscopic surgeries. So the question that still haunts us is whether ESP definitely produces visceral anesthesia. Some answers have been given by this particular article. Coming to spine, the lumbosacral spine surgeries, this is a case series where they did 6 cases and they gave bilateral blocks. There was no effect on somatosensory potentials, and they had opioid sparing and enhanced recovery. And this comes from India as well, and they mentioned low VAS scores. And there are several articles which I have also gone through which might be published in future about the use of these blocks for the spine surgeries as well. We have seen the cadaveric as well as the clinical trials. We come to the contrast studies, and they mention this group, they mention the use of 30 ml contrast spread, which is deep to the erectospinal muscles, and it goes into the intervertebral foramen at all these levels. It goes around the epidural space, the anterior lateral and the posterior epidural space. So this is a contrast study where they did an MRI imaging study, and they found that the contrast does go into these particular spaces. Sometimes back, myself and Abhijit, we mentioned about the spread of the contrast, which spreads from the erectospinal plane through 2 paths. One is through the dorsal rami path, and the second is through the costotransverse foramen, and it goes into the foramen and then into the epidural space posterior, and then goes on to the other side. Now remember that this is the injection just on one side, and this is just 10 ml, and you give bilateral injections, it's going to cause a hemodynamic compromise in maybe a critical ill patients, and that's why you need to be very, very cautious. After you give the first block, you monitor for 10 minutes, and then maybe you can give the block on the other side. Coming to analysis of local anesthetic volumes, this particular author, he studied several of these case series where they used 20 to 30 ml at different sites, and they found the spread from T1 to T12 and sometimes to L4. And the volumes that he mentioned is a mean of 3.4 ml per dermatom. So this might be a reference value for your future studies when you start using it for the thoracic procedures. The last would be the analysis of literature evidence. Now, this is a randomized controlled trial which they have used. These authors who come from most of them are from Turkey, and there's 2 from India as well. And when they use this forest plot, they found that it favors most is in the favor of ESP when they use it versus the controls. And they also found a reduction in the opioid for the first 24 hours with a prolonged time to first analgesia, and the reduction in rescue analgesics as well. Now, what contribution we have done in erectospinal plane block through our studies? So we did the cervical, thoracic, and lumbar studies, as I have mentioned it earlier. The lumbar is one which we are still writing upon, and this is the cervical cross sections where I injected dye at the level of at the level of T1, and we found that in the contrast it goes between the medial and the lateral erector spinae along the course of the dorsal rami, and it goes right up to the dorsal of the ventral root. It really doesn't enter into the foramen and doesn't go into the epidural space. But the same thing when we injected this is the same cadaver where we had injected the contrast, and we found that the dye had gone right up to the anterior scalene muscle. We had dissected 4 of them, and we had injected in 4 of them, and just one on the right side. On the right side, it showed the dye on the anterior scalene muscle, and it also was in between the fat plane of the sternocleidomastoid and the anterior scalene muscle. That means that in this particular, it did block the phrenic nerve as well as the supraclavicular nerve. But overall, we had a 75% phrenic sparing if you consider the cadaver studies. This is a thoracic cadaver. You are seeing the sagittal section. This was described the last time. If you look from the back, this is the skin and the subacute. This is the erector spinae muscle, and this is the transverse processes. Joining the two is the intertransverse ligament. Joining the rib and the transverse process is the costotransverse ligament. So the needle, if it is deep to the erector spinae and superficial to the ITL, is the deep erector spinae plane block. But if it goes beyond this barrier, then it is in the costotransverse space, which has been described. And if it goes beyond the superior costotransverse ligament, it is in the paravertebral space. This is the ventral nerve root. That's the dorsal nerve root. So anything we inject behind the superior costotransverse ligament will be a dorsal nerve block unless the local anesthetic, it seeps through the costotransverse ligament and blocks the ventral nerve root. So that is the inference that we get from this anatomical description. Some of the clinical studies in our hospital include the cervical ESB for the shoulder surgeries. As I described earlier, we did 5 cases, and we found that the contrast, it goes to the dorsal of the ventral rami, not into the neuraxial space, and some of it goes into the paravertebral space, and it blocks the dorsal as well as the ventral root. There's no dye over the phrenic or the anterior scalene muscle close to the phrenic nerve, so we mentioned as a phrenic sparing, and we are now conducting a pilot study of a certain group of patients. The use of perioperative management for cervical spine surgery, we described this when the patient is in a prone position. We insert catheters bilaterally at the level of T1 with the catheter going cephalad, and then we inject local anesthetic. We find that from C2 to T1, you have good amount of relief of pain over a period of 48 hours. We connect this to the infusion pumps at 0.1% ropivacaine at around 5 to 6 ml per hour. Postoperatively, before removing the catheters, we do contrast studies. We see the contrast going in the paravertebral space and nothing going along the ventral root and nothing going into the neuraxial space in the axial as well as in the coronal sections. So it means that this can be a motor sparing as well as a phrenic sparing block. This is the immediately after the operation, there is a rapid recovery, and you will see that the patient has got a normal neurological function. So this is what we have been using for the posterior cervical instrumentation and decompression. Coming to thoracic, we described in scoliosis, where we injected on the concave as well as on the convex sides. We found that the concave requires more volume of local anesthetic than the convex side, and you require multiple injections on the concave and maybe single or just 2 injections on the convex side. And we found that it has got again opioid sparing activity as well as the requirements of total intravenous anesthesia, that is propofol, dexamate, and fentanyl consumptions are really less than when you don't use erectospinal plane block for scoliosis surgery. Again, to keep in mind, we also reported that it doesn't have any effect on somatosensory evoked potentials, which we monitored every time when we did an erectospinal plane block for scoliosis surgery. For polytrauma of the spine, yes, we used we reported this in patients with multiple rib fractures, and the same patient fractures of the transverse process and the sacroiliac joint, and we found that this contrast, it goes into the paravertebral space here in the sagittal as well as in the axial planes. And this would be a definite contraindication because this patient had some amount of spinal cord injury, would be a contraindication for the thoracic epidural. So, and this would have never reached the lower levels where you can see the contrast right from T7 down to the level of L4. So this is really helpful in patients with polytrauma and spinal cord injury as well. In the lumbar ESP, we reported that when you inject a volumes of around 40 ml or 40 ml of local anesthetic behind the transverse process in the axial oblique plane, we found that the contrast goes into the foramen and it blocks at multiple levels the ventral lobe, and that's why it obtunded the knee and ankle reflexes. So this cannot be an ambulatory block. You need to be careful. So we always monitor whether the patient has got foot drop or quadriceps weakness after a lumbar erectospinal plane block. So we find that it's a volume dependent spread because this is not reported, but we would do that soon. This is a 10 ml injection, that's the 20 ml, that's 30 ml and 40 ml local anesthetic. So as you keep on injecting the volumes, it keeps on spreading into the psoas major and it blocks the lumbar plexus as well. This is called as the coronal axial plane, where you can see multiple spinous processes and multiple transverse and processes as well as vertebral bodies. Now coming to the last part is the sacral ESP. Now myself and Arunanshu are working on this as well as Abhijit. We are working on this acute and chronic sacroiliac joint pain, and what we found was very interesting in this. Now this is the foramen that you see is the gap on the sacral plate. This is the sacral foramen second. This is the sacral foramen third. That's the caudal epidural space, and is the sacral multifidus. So what we do is we insert the needle at this particular point just under the sacral multifidus, and we inject around 20 ml of local anesthetic. And you can see the spread. It obtunes all the dorsal foramina here. You can see that, and it spreads right up to the level of T12, and that's a huge amount of spread that we find. And this has also been reported by Tulgar from Turkey. But more interesting was, since we found that the patient had numbness in the foot as well, we took her to the imaging under CT scan. We found the contrast spread, which was from the dorsal rami here into the foramen, and then into the ventral foramen, and then going into the epidural space and along the sacral plexus. So that was the spread, and this spread also was medially along the caudal epidural. So you cannot really compare a sacral with the lumbar, with the thoracic and the cervical, because these are all different kinds of plane with different kind of muscles and different kind of apertures and the holes that the foramina that you can see like this. So this is what we now use is in sacroiliac joint pain for post-traumatic and metastasis with a single short catheter, and we are trying to report this into one of the journals as well. So the current application for thoracolumbar, we use it for spine surgery. That is the placement of the catheter, and this is a radiopaque catheter that we place, and you can just take an image. You don't have to inject contrast because you know the spread of the contrast, and this we use for multi-segment lumbosacral spine surgeries. The next is a patient who was anticoagulated and had a dual erectospinal plane block. You can see 2 infusions. He had a cervical trauma as well, which was not operated upon, but he had a proximal humerus and a proximal femur for which he had 2 infusions, one going into the cervical and one going into the lumbar area. The cervical area, this is the upside down. That's the dorsal part. That's the ventral part. You can see from the dorsum, it coming along the path of the dorsal rami. This is the medial erector, that's the lateral erector, and it goes right up to the dorsal rami, and it will stain just the ventral dorsal part of the ventral area. This is the catheter coming into the transverse process, and if you inject local anesthetic, again there will be a spread in the erectospinae. A partial spread in the lumbar plexus can be also visible at times if you increase the volumes. So the ESP will reach where the thoracic epidural and paravertebral blocks can be contraindicated or cannot be given. For example, this is a complex scapular surgery that we do. And you cannot really give a paravertebral block, or you cannot keep you cannot do a thoracic epidural in this case. This patient also had an iliac crest, and you could see the sensory dealination. And somebody was saying about the role of the interfacial plane blocks for the iliac crest. Now, this is the area which is supplied by the cluneal nerves. Now, this cluneal nerve, it arises from the level of the lumbar, the dorsal, and then it goes along this. So the erectospinal plane will definitely help in blocking the cutaneous area as well, but we are not sure about the osteotome or the bone. So the advantage is it facilitates opioid sparing. There will be early extubation, and you've already seen effective physiotherapy in the post-operative period and mobilization following surgery, as we have seen in all these patients. Complications, pneumothorax has been reported in one of the patients. You need to be very careful when you do this in scoliosis, because the pleura will be very, very close and the muscles are thinned out. The erectospinal muscles are thinned out on the convex side, and you need to be very careful in that. Unexpected motor weakness, it was reported earlier, and we also endorse this particular thing, and it can be a non-ambulatory block. You have to be very careful. You have to monitor the quadriceps weakness as well as foot drop. Some of the points to remember that whenever you do a interfacial plane block, you need to evaluate the invasiveness of the surgery. If it's a soft tissue surgery, or it's involving the bone, it's involving the dermatome on the other side, if it's crossing the midline, investigate the anatomic area of tissue dissection, assess the dermatomes, myotomes, and sclerotomes of each surgical site. Block selection is based on clinical evidence. Now you have a lot of evidences for erectospinal plane block or any other interfacial plane block. Go through that, and then you can really come into conclusion which block to be used for which surgical procedures. You need to understand the ongoing breach or gap in the knowledge. This is very important, and you have to have additional research in process. And you need to be updated all the time about the interfacial plane blocks. And then you make an assessment and then conclude that this interfacial plane block would be best suited for this type of surgery. For example, if you take breast, we know that the PEX and SAP would be more better than ESP block. Of course, there is no randomized controlled trial between these two blocks. So in my opinion, if you consider this as a cross section, the ESP is a dorsal rami block, which is used for all dorsal surgeries. Since there's an inconsistent ventral spread, it can be rarely used for ventral surgeries, but there are reports that it is now being used for ventral surgeries as well. And this could be because of blockade of lateral cutaneous nerves as well as some of the anterior cutaneous nerves. Now, if you consider some of the recent changes in the nomenclature of the anatomy or the dissections of the anatomy, they have found that there is a differing type of innervation of all these muscle groups, and that's a total different topic. And this might be one of the reasons why the erectospinal plane block might act through the dorsal rami. It's a high volume block, and the plasma local anesthetic levels have not been monitored as of yet. I'm not really aware of this thing, and this has to be done because we do inject 20 to 25 ml bilateral, and then we keep them on infusions for almost 24 to 48 hours. So these things have to be monitored as well. Some of the RCTs are required in future considering this block with the gold standard, and there are, I think in clinical trials, I've seen a lot of these blocks now are being compared. Soon we'll be able to have a definite answer to all these questions. Some of the gray areas to be answered are all the ESP same like the cervical, thoracic, lumbar, and sacral. I have demonstrated through cadaver and the contrast studies that they are not the same and they can be different. Would it be possible to simplify the nomenclature? We have recently uploaded an article regarding this, and maybe soon it would happen, and this we had discussed the last time. The volumes in cervical and lumbar erector spinae have not been yet clarified. The thoracic, to some extent, yes. Is it a volume-dependent block? Yes, demonstrated through the contrast that in the lumbar area, definitely it is. Whether you require catheters or no catheters, they have not yet studied. Ambulation or no ambulation, yes, you have to be very careful when you need an ambulation, particularly for the lumbar erector spinae. We are not. It's not a problem with the thoracic. With cervical, yes, we do ambulate the patients with the cervical catheters as well. Sacral ESP, does it work? I think it works and it might change the future. Myself, Abhijit and Arunanshu, we are working on that right now, and we see that it might be used in certain kind of surgeries that has not been described in the literature as well. And the last thing is, does ESP fail and how do you rescue it? At least there is one article which mentions that the thoracic paravertebral block, in fact, has been used as a rescue analgesic for ESP block. ESP block, yes, it does fail if your catheter is not in the right place. I've got certain contrast studies which I have not included in this talk, but yes, I had failures with the ESP as well. So thank you very much. If you have any questions, I'm happy to answer those. Thank you, organizers of AORA, Ritesh, Murli, as well as Dr. Vandana. Thank you very much.
Thank you, Dr. Sandip. It was a comprehensive talk bordering on a masterclass on ESP block. We have a few questions from the viewers here. The first one is regarding the use of ultrasound and for people without ultrasound, what is the strategy?
Yeah, so Murli, I think you and me were performing thoracic paravertebral blocks with loss of resistance technique, where you used to hit the costotransverse junction and just go beyond that and inject your local anesthetic. Now, the difference is of just 1 centimeter. If you come just 1 centimeter behind the paravertebral space, just you hit the costotransverse junction and you give the local anesthetic. So that becomes your erector spinae plane block. The only thing is that you're not visualizing the spread of the local anesthetic agent, but I think it should be as good as what it spreads under ultrasound as well.
Okay, that's the first one. The second question was regarding cervical ESP, which you already answered quite comprehensively. The third question was, can these blocks be used as sole anesthetic?
Sole anesthetic, no, it cannot be used. It's basically a dorsal RMI block. We have tried in a few patients in whom a soft tissue surgery, like maybe a lipoma excision or maybe a hemangioma excision on the dorsal aspect. But then we really could not block all the dermatomes in this. So I think it cannot be still used as a sole block. Of course, there was a study we've done by Tulgar, which has been included in the Indian Journal of Anesthesia. I'm quite surprised how the reviewers could say yes to that article. He used erector spinae plane block and chordatus lumborum block for hip surgery, and he used the amount of propofol that he used was equal to the anesthetic as an anesthetic agent. So I really am surprised by this particular article.
The next question is, I think somebody needs to. Okay, the next question is regarding the difference between a thoracic paravertebral and ESP, which already you have answered, and which one is better for post-mastectomy pain. Any comments on that? Just a one-liner, which you already have covered in the.
Yeah, thoracic paravertebral, yes, Mowgli, I have used it in the past for sole surgical procedures. I demonstrated that in a couple of workshops in the past. It does block the motor, sensory, and the sympathetic nerves. I'm not sure why the paravertebral block is not getting obsolete, but there is a certain group which really mentions that its erector spinae is RIP2 block. I'm not sure about why this was mentioned, but definitely paravertebral block has got its own place, and the erector spinae plane block has its own place.
Your experience of ESP for PCN?
No experience. I'm just orthopedic.
Okay. Now, with regards to ESP, again, you already covered this, but the question was from Dr. Smritija. Why is ESP block not so well defined in the lumbar region as compared to thoracic? And is it due to the decrease in bulkiness of the muscle in lumbar region?
The ESB is not described, she says, in the lumbar area. So if you can go through the article by Xavier Salablanche in Radar. The Radar is a Spanish journal of anesthesiology. And he mentions at the level of L4 where he injected methylene blue dye in 6 cadavers and 12 specimens. And he found that less than 50% of the times the methylene blue dye, it trespasses and goes into the lumbar plexus. This is one thing that I found, and my study with contrast, which will soon publish, also we also have seen that if you keep on increasing the volume from 10 to 40, there will be a translocation or migration of local anesthetic from the dorsal to the ventral. Of course, as I mentioned earlier, the situation of the muscle groups in the lumbar, thoracic, and the cervical are different. 3 in lumbar, 3 in thoracic, and then it becomes 6 in the cervical area, and it becomes just 1 in the sacral area. So each has got different mechanism of spread and dynamics.
Sure. And another, I think this will be probably the last question regarding acute pain management in spine fractures.
Yeah, so acute pain management, I described, I think. And
you did.
Yes, and there are certain articles which mention the burst fractures, then the L4, the transverse process fractures. All these are being managed by erectrospinal plane block, and this is one area which we are where you can use catheters and you can decrease the amount of pain. Yes, it can be used.
Okay,
I think for the what they call it as what do you do? You put cement into the vertebroblastis.
Yes. Okay. So I think with regards to the questions, we have more or less covered. And
Murli, can you? Murli, I'm Dr. Vrushali here. I just have 1 or 2 questions for Sandip, if with your permission.
Yes, please. Yes, please.
Sandip, brilliant. I enjoyed your presentation. I want to revisit 2 slides of yours, if you don't mind. Can you please, because I have certain queries on it. I want to see the slide in which you elaborately showed the cervical transverse section and showed the catheter.
The one in which it felt like it was going in.
Yeah.
This one?
No,
yes.
The lower one.
No,
no, lower down.
This one?
The catheter in the cervical spine, in the transverse section of the neck.
Lower down. I think there was one in which.
I'm not sure which one. This one.
This one. That one. Yeah. That's lumbar. That's lumbar.
So that's not the catheter, Roshali. That's the contrast which is going into the in between the medial and the lateral erectrospinae.
All right. Okay. Then can one more? Can we go to the cadaveric study of yours in the neck, where you have shown the contrast going right up till the anterior aspect of the neck?
Yeah. So
because
Roshali,
I have pondered on that transverse section for quite some time.
Yeah. So this.
Yeah.
Yeah. So this was exactly given at the level of T1 with the bevel directed cephalad, and the injected was in the cephalad direction, and the cross sections were taken at mandible, which is at the level of C2, at the hyoid, which is not shown here, at the level of C4, and the cricoid, which was at the level of C6. And in all the sections, we found that the contrast spread from the dorsal in between the lateral and the medial erectospinal group, and it goes right up to the transverse process here, and then it spills off somewhere here at this point where it dorsal to the ventral root. It doesn't go in and block the soak the ventral, and it doesn't go into the neuraxis, and it doesn't go over the scalene group of muscles, so it doesn't block the phrenic. But when we did this injections, and we did the cadaver study first, and then we freeze the cadavers, and then we took cross sections. So when you inject contrast, and we took the CT image the next day, we found the contrast going in one specimen on the anteroscalene muscle, and in the same we found it going between the fat planes of sternocleidomastoid and the interscalene muscle. This is where exactly the supraclavicular nerves they lie. So this demonstrate that this could cause a phrenic nerve block as well as a supraclavicular nerve block. But that was in just one specimen out of 4. So that means 75%. It doesn't cause a phrenic nerve block.
If it was, no, this is just for my clarity and understanding. If the transverse process and the erector spinae, and if the space in between the two is your erector spinae block, then our contrast should be even there as well, or the dye should be there as well. So
that's why that's why I call it as a mysterious plane. Now, what you say, I correct. You mean the contrast should be somewhere at this point, isn't it? And the contrast never
posterior to that, I guess.
Yes, posterior to that.
Isn't it even posterior to that? Yes,
exactly. So what the other group has done and recently presented a cadaver study in cervical, they injected this at the level of C6. And they injected a huge volume of around 20 ml. And then they found that it goes into the brachial plexus and blocks it. I mean, it soaks those nerves.
That is imaginable, yes.
Yes.
But then you have done it under ultrasound, right?
Yeah, ultrasound, but at the level of T1. Remember, the shoulder surgeries, all the proximal humerus surgeries, they require from the level of T1 to C6.
Maybe it was likely lateral and an injection perhaps might give this. Would you agree?
I'm not sure, because there is a change in the muscle group and the fascial planes when you go from the thoracic to the cervical area. The whole thing changes. So definitely something that we commonly see when we inject in cadavers.
Yeah, okay.
And I think I have a last question which has just come up now. The difference between intermittent bolus and infusion in ESP catheters.
Yeah, we do intermittent boluses. We do it. So that's on patient demand. That just when the patient starts having small changes in the vas course, we tell him that it's time for his injection. So the nurse actually gives that. We have trained the nurses to give that. So we don't have to be there all the time.
Okay. Dr. Sandip, it has been an excellent session. Dr. Amjad as well. I need to say very comprehensive lectures. And we have covered most of the questions that the audience has come up with. I hand over the mic to Dr. Ritesh to take it forward.
Thank you, Dr. Amjad, Dr. Sandip, sir, for an excellent presentation. Thank you, Murli, sir, and Vanna, madam, for moderating this session very nicely. Thank you, Sonosite, for providing us their Zoom platform. Thank you. Special thanks to Savita from Sonosite. Thank you, Anesthesia TV, for the live streaming on their platform. And most importantly, thank you all the delegates. Without you, this webinar would not have been success. I request all of you, you can download your certificates of this webinar after a few days by logging in onto the AORA AORA account, and you can download your certificates. And this webinar series will continue. See you all on next second Saturday of next month. Till that time, be all safe, take care of yourself, and be safe. Thank you. Thank you very much. President ma'am, you want to add something?
Thank you, Ritesh.
Thank you. Okay, bye-bye. Bye-bye.
Thank you, everybody. Thank you, Ritesh, Amjad, everybody.
Thank you, everyone. Thank you, Ritesh.